Okay, everyone, welcome back. It's 6:30, so we'll go ahead and get started with the class portion. This week and next week, we are talking all about healthcare adaptations. So, how a child and their family responds to being hospitalized. So, the very first thing that we do when a child is admitted to the hospital is we have to get informed consent. So, this is the parent or guardian signing a piece of paper saying that they give us permission to treat their child. So, we typically do it before we provide any care when they're admitted to the hospital. And then we'll get additional consent for any invasive procedure or surgery that we do. So, when we are doing an invasive procedure or surgery, we have to make sure that we explain everything to the parents and that they fully understand all the risks that are involved. And them signing away gives us the opportunity to be able to treat their child or do the surgery. So it's our responsibility to make sure that that happens before the procedure begins. When possible, we need to include the patient in the discussion. So anyone under the age of 18 isn't able to provide consent for themselves, but they can be included in the discussion. So just making sure that we aren't excluding the child. We also have to make sure that we have accurate identification for our kids. They need to have an ID bracelet put on as soon as they're admitted to the unit, and their parent will also be given an ID bracelet to wear to match their child. So that's how you can match your parent with your child, is making sure that their ID bracelets match. We need to make sure that they are verified before we give any medication, any treatment, or we take them for any procedure. So most of our medications require barcode scanning. So that requires you to actually look at the patient's wristband before you give your medication. But making sure in a downtime or any time that we're giving meds or doing a procedure that we're double checking and making sure that we have the right patient. You can have situations where you have twins in the same bed and you can't tell who's who if they don't have a bracelet on, or your patient might have changed rooms. All of those things can be really easy ways to mistake who you're actually supposed to be caring for. When we're putting bands on children, we need to make sure that they're not so tight that they cut off circulation, but that they're not so loose that the child can easily slip them off. And then make sure if you trim the end of the band that you make sure you don't leave any sharp edges that could cut the child. And then when we discharge, we need to make sure that we're verifying that parent band again. So we're discharging the correct child with the correct parent. We typically check their photo ID too. So being in the hospital is a new environment. So especially our toddlers find all these new things that they can play with. So there's some extra things that we need to do as nurses to make sure that we're providing a safe environment. We need to make sure that we always have the crib side rails up when the child's alone in bed. Even when we're doing our cares or we're at the bedside with the child, anytime you turn your back to the bed, you need to make sure that you have a hand on the child at all times. So they're really easy for them to roll out, jump out in the blink of an eye. So making sure that we have those side rails up, or we at least have a hand on the child. We need to make sure that we're IDing them by their bracelet and not by their room or bed number. We know that patients move all the time. It's really easy to end up in the wrong room too. So making sure that you're using that double check and taking full advantage of that. For our climbers, especially our toddlers, we may have to do some extra safety measures besides our crib rails. So if we have a kid that likes to climb and is one to climb over top of that side rail, then we also have plastic that we can put at the top. So the bed becomes fully enclosed and they can't get over that side rail. So that's something that we might have to consider if we have a climber. We need to make sure that when we place cribs in the room that they're not up against things that the kids shouldn't touch, that they're not near outlets. You know, we have outlets in lots of different heights on the walls. So making sure that they're not in reach of anything that they shouldn't be touching. We also need to inspect our toys, just like we tell parents to make sure there's no sharp edges, no removable parts that they could swallow. All of those are important things we need to model for our parents. Then it's really important that we keep our medications out of reach, making sure that they're in a locked drawer so that we don't have anyone potentially tampering with them. We make sure they're out of reach of the children so that we don't have an accidental poisoning, so that we can account for all of our medications. Another thing with toys and with point of care equipment that we have to watch out for is cross infection or cross contamination. So if we take a toy into a room, take it out for another child because our kid's done playing with it, if we don't fully disinfect that toy, we're taking the germs from baby one and giving it to baby two. So making sure that we're just using our infection control measures, especially with kids that are in isolation, we need to make sure that there's a nice bit of downtime for that full disinfection window before we're giving that object to another patient. And then we need to take proper precautions when we're using oxygen. So making sure that there's no open flames in the area, that the oxygen tank is upright and secured. So I don't know if you've ever seen the videos, but if an oxygen tank gets knocked over, it can bust the seal on the top and it propels across the room like a rocket. So that's why we make sure that anytime we secure an oxygen tank, that it is actually strapped to something so it can't accidentally tip over. So we don't want that propelling across the room or across the hospital. We also need to make sure that our ambulatory patients aren't using wheelchairs or stretchers as toys. So they're only used for transporting patients. We need to make sure that if we have an active child, that we don't leave them unattended in a swing or on a feeding table or high chair where they could tip over or fall. We talked about never leaving a small child unattended out of the crib. There's just too many opportunities for danger. Also, you really don't want them crawling on the floor. The floor is disgusting. So definitely don't let them crawl around. Don't leave meds at the bedside. And then another thing that we need to watch for in the hospital setting is bottle propping. So a lot of times parents are going to be really exhausted. They just need a little bit of time to themselves. So they just prop the bottle in the mouth of the baby so that they can close their eyes for a second. That is extremely dangerous because of the risk of choking. So just like if somebody were to tip a cup up in your face and all that liquid comes flooding down at you, the same thing's happening to a baby if we prop a bottle in their mouth. So they can't control the amount of liquid that's coming in and they're at risk for aspiration and choking. So making sure that if we see parents or nurses propping bottles, that we immediately stop that behavior. When we're transporting, we need to make sure that we're using appropriate methods based on their age, level of consciousness, and how far we're traveling. For older children, we can transport them just like we would adults. For our younger kids, we can use cribs, wagons, we can use the smaller pediatric wheelchairs. We still need to make sure if we're using a gurney or a stretcher that the side rails are up. Same thing with the crib. Make sure that we're checking that ID bracelet before we leave to make sure that we're taking the right child. Making sure we have all of our safety equipment as well. So in case of emergency, you have everything that you would need to be able to resuscitate a child. And then we need to make sure that we do proper documentation. So making sure we document what time we leave, how we took the child, where we went, who went with them, the fact that we have all of our safety devices with us, and then when we get back. Those are all important things to document. And we know that we do a lot of assessments and a lot of data collection, especially on our children, because they can't tell us what's going on with them. So we're reliant on our data collection and our assessments to be able to fill in those gaps of what they can tell us. We use that to determine their level of wellness, how they respond to medications, and what types of referrals they might need. So when we're doing our assessment, especially with our infant population, it's really important that we follow a systematic approach. So we want to make sure that we have a welcoming environment. So starting with a room that's warm, non-stimulating, that's going to keep them nice and calm. We want to make sure that we start with the least invasive parts of the assessment and then move to our most invasive. So we want to start with just observing the child, not touching them, just observing at a distance, letting them get used to us and seeing that we're not going to hurt them. Their first impression is going to be that you're there to poke them. So giving them that chance to warm up to you, talking to them, engaging with them, making sure that you're doing all your observations that you can before you even touch. Then when we are getting ready to examine the child and be hands-on with them, we want to make sure that we're only exposing one body part at a time so that they can stay nice and secure and cuddled up with mom and dad. And that way they stay calm a lot longer. So only expose one part of the body that you need to assess and then cover it back up. Make sure that we're talking nice and soft. We let them use their pacifier. Let them stay with mom and dad as long as you can. The more you can do in mom and dad's lap, the more calm your child is going to stay. We can swaddle and hold after we're finished with the assessment and during the assessment, as long as you don't need to see the body part. And then use that opportunity to teach parents about normal signs, abnormal signs, teach them what you're looking for. Great time to help with development and motor skills, kind of cluing them into what baby's doing. And then make sure that we're documenting our findings. So when we're doing our observation, we want to look at the overall look of the child. How do they look? Are they appropriate for a child their age? Do they have the right size? Are they doing the right developmental skills? How do they interact with their parents? Are they withdrawn? Are they engaged? Do they have that appropriate fear of strangers? Things like head tipping or rubbing their ears can be an indication of an ear infection. So looking for those little cues that might tell us there's something going on that we should take a closer look at. We want to also look at their breathing. Do they have a real rigid body posture? Are they having difficulty breathing? Are they using their accessory muscles? We also want to look for any bruises that we might see, especially in various stages of healing, or cuts that might be indications of abuse. When we're doing that, we need to be careful of alternative forms of treatment. So if you look at the picture here, with all what looks like bruises on this patient's back, this is actually a Eastern medicine treatment called cupping. So it's totally normal in some cultures, but can look very similar to bruises. So you'll see a lot of professional athletes will participate in cupping to increase the blood flow to their muscles to help quicken the recovery after a race. Swimmers do it a lot. So you need to be careful that if you do notice a bruise on a child that looks like really nice and circular, real even edges, nice clean edges to it, that you ask about those alternative medicine treatments, just so that we're not causing alarm where we don't need it. And then the last thing we look for is the overall cleanliness of the child. And that can be indicative of additional resources that might be needed, or if we have a neglect situation. So when we're doing our history survey, this allows us to provide extra education to parents, as well as give them those injury and illness prevention tips as we're obtaining the history. We should make sure that we include questions about any alternative medicine or complementary treatments that they do, any over-the-counter medications that they use, and their immunization history. We also need to know about the child's eating habits, sleeping, toileting, their normal activity, and then any special words or gestures that they use to communicate so that we can have a better understanding and make sure that we're aware of those. When we do our physical survey, we're going to do that head to toe assessment on admission and then once a shift or at every clinic visit. We're going to do our vital signs like we normally do. We're also going to address their hydration status. So does anybody know how we check for hydration in infants?
Their fontanelles.
Yep, exactly. So a flat fontanelle or their soft spot is going to be a good indication of good hydration. If they have a sunken fontanelle where it's a big divot, then it's a sign that they're dehydrated. If their fontanelle's bulging or it's a big rounded bump on their head, kind of feels like a goose egg, that can be a sign of increased intracranial pressure, which is definitely something that needs to be addressed immediately. When we're listening to their heart sounds, we want to watch for tachycardia in our infants and young children. That is one of the very first signs of shock. So if we can treat when we're tachycardic, then we'll be much more likely to have a good response, as opposed to waiting to the very, very last sign of shock, which is hypotension, because the body's already compensating for the overwhelming infection. So if we wait until we have hypotension, we've already missed the boat and we're in an emergent situation. When we're listening for our lungs, we need to be paying attention to any extra sounds that we have. We need to look for any abnormal breathing. So are they retracting through all of their ribs? Are they sucking in really hard to breathe? Do you see their nostrils flaring? Those are all signs that the child is having difficulty breathing. And then when we're looking at their skin, we want to look for any rashes or lesions. Something that you can see, especially in our infant population, is mottling of the skin, where they get that real pale, marbly look to them. They look really pale and then real veiny. So kind of look like marbled cheese. That is the body's way of decreasing perfusion to the extremities so that we make sure that the core organs are all well perfused. So you see that in our infants a lot. Looking at our pulse and respirations. So the most common sites for our pulse are going to be radial, temporal, mandibular, femoral, and carotid. We advise an apical pulse in children under 5 years of age. So if you've ever listened to a baby's heartbeat, you know it gets real fast, slows down, gets real fast, slows down. It's all over the place. So if you only listen for 6 seconds, you might miss some of those fluctuations. Same thing if you tried to take a pulse, a radial pulse like you would an adult, you might miss those fluctuations. So that's why we really encourage you to listen for that apical pulse for a full minute. Once we're over 5, then our radial pulse becomes a lot more reliable. Respirations, we talked about paying attention to both the rate and the character. One thing to note is as the pulse rate increases, or the pulse rate will increase as your temperature increases due to the increased oxygen consumption. So if you're really, really hot, you're going to consume a lot more oxygen, and that's going to make your heart rate go up. And we definitely want to assess our respirations when our infant is nice and calm and quiet. So that's going to be one of the very first things that you're going to do. when you're doing that observation piece of your assessment. Our blood pressure is likely going to be the next thing that we do after our respirations. So hopefully you can take a blood pressure before you've unwrapped the infant in any way, shape, or form. You could just sneak out an arm or a leg. When we're choosing our blood pressure cuff, we want it to be 2/3 the size of the upper arm. Same thing, if you're doing a leg blood pressure, make sure that it's an appropriate size, so 2/3 the size of the extremity. We can either use electronic blood pressure machines or we can listen to auscultate our blood pressure. Obviously, it's going to be lower than an adult blood pressure just because they don't have the blood volume that adults do. There are multiple locations that we can take a blood pressure, which is really nice in our infant population when we're trying to only unwrap one thing at a time. And then we want to make sure that our infant is not crying when we take a blood pressure so that we're getting an accurate reading. So if they're crying and they're upset, their blood pressure is going to be artificially elevated. When we're assessing fevers and whether or not to treat, we need to remember that a fever is a normal response of the immune system to an infection. So when we have a fever, our immune system works with our prostaglandins to stimulate our hypothalamus to bring up the body temperature. So that's what's causing our fever. You'll see vasoconstriction and shivering, decreased peripheral perfusion. So that's where you'll see that modeling. And then decreases in body heat lost while the patient is fighting the infection is how the body maintains homeostasis. If we give antipyretic medications, so Tylenol, ibuprofen, any of those fever fighting meds, we can inhibit the body's prostaglandin production, which will decrease the body's natural immunity to fighting off that infection. And then anytime we have a fever, we're going to have increased metabolic demand on our heart and lungs. So that increased temperature is going to coincide with that increased heart rate. So remember that all of those go together. Very different from a fever is going to be hyperthermia. So it's also an increased temperature, but this occurs when we have central nervous system impairment. So there's been some sort of trauma that has caused central nervous system impairment, and now the body is unable to regulate the body temperature. We don't have any prostaglandin involvement, and there's no homeostasis mechanism. We treat this with vigorous cooling measures. So in the top picture, you see an infant being cooled using whole body cooling. So they either have those wraps that go around the body, or we can lay them on a cooling blanket, and we use their core temperature to help regulate the temperature of the blanket to make sure we bring them back down to normal. For our older kids, we have the bear hugger blankets that you see in the bottom picture there. And those are just filled with water that circulates through and is controlled by a machine to help regulate the body temperature. So it will fluctuate as the patient's temperature changes. When we're assessing our temperature, we have lots of different methods that we can use. The important thing to remember is our core temperature is going to be our most accurate. The other ones are all a variation. So if you take an axillary temperature, it's typically a degree lower than your core temperature. So just keeping those things in mind when we're deciding whether or not we want to treat, making sure that we're not freaking out if our baby is just a little bit cold, because there is that little degree of wiggle room. And then making sure that we're not jumping to treating a patient just because they have a slightly elevated temperature with one of the less reliable methods. The other thing is we don't widely recommend core temperatures, so rectal temperatures, because of the risk of inserting the thermometer too far. Our fifth vital sign is going to be our pain assessment. So it has to be included in part of our care plan. And we have to make sure that we're using the right pain scale for our patients. So if they're nonverbal, we want to make sure that we're using a nonverbal scale like our FLAC scale. So that's going to look at the overall appearance of the child. It's going to look at their facial expressions, how they're moving their legs, what their overall activity is. Are they crying? Can we console them? And put all those factors together to determine what level of pain the child is experiencing. So we can use that with our nonverbal kids, our infants. There's modifications of that for our younger population and our premature infants that's more appropriate to what they would do. The other scale we have is our FACES scale. So the child picks out what face corresponds with how much pain they're in. You have to be careful because sometimes they might just pick out the one that they like the best and not necessarily tell you their pain. So take that into consideration when they're giving you their response. We also have a number scale 0 to 10, just like we do for adults, that we can use in our verbal adolescent patients. They're going to be able to tell us 0 to 10 how bad they're hurting. So just making sure that we're using a developmentally appropriate scale. Our weight is going to provide us a means of determining progress. So as we're plotting their weight on their growth chart, we're able to see how they're progressing over time. Are they being adequately nourished? Are they still on track with their peers? We also need it to determine our safe medication doses. So that's how we're going to do all of our dosage calculations for pediatric patients, is based on their most recent weight. When we're weighing infants, we're going to lay them on the scale and they will likely be naked or just in a dry diaper. So if you do weigh them with a diaper, you need to make sure that you either zero the scale with the dry diaper before you put them on it, or that you subtract the weight of the dry diaper from their final weight. Our older kids can be on a standing scale just like an adult would be. When we're looking at height, infants through 2 years of age will be measured flat, lying flat on a surface. So we can either use a tape measure like you see there, or we have a length board that's going to have a spot to line their head up, and then it's going to have a slider that will go up to their feet to measure their length. It's really important that we use 2 people to measure an infant's length. One to hold the head at the top of the board so that they can't slide down, and then the other one to extend their legs and hold their legs extended and then adjust that bottom slider to their feet. Otherwise, it's really easy for the infant to just slide around on that board and not get an accurate measurement. Children will be weighed standing just like adults are. 2 to 18 can be standing. It's important that we measure head circumference on all infants and toddlers. So we do this with a tape measure that goes just above their eyebrows and then above their ears and around the occipital prominence at the back of their head. Does anybody know why we measure head circumferences?
I think that
To see if the skull is healing properly or
growing.
water on the brain.
Yep. Yeah, so monitoring their growth. So head circumference is one of those things that we need to watch and look for that steady progression. The other thing is if you have a sudden change in your head circumference. So you've always been measuring 23 centimeters, and then all of a sudden you're 30 centimeters. That is an indication of hydrocephalus. So they have water on the brain, they have increased intracranial pressure. There is something going on that needs to be urgently evaluated. So a sudden increase in head circumference means we've got something going on that we need to look at. And the last thing that we do every time a kid's in the hospital, we love to get labs. So when we're collecting specimens, no matter what kind of specimen we get, we follow the same process. So the very first thing we do is we verify our order, making sure that we know what it is that we're supposed to be getting. Once we know we have the right order, we need to make sure that we have all the right paperwork to go with it. Make sure we have all of our supplies. So gather your containers, any supplies that you might need for a procedure, making sure that you have your labels and your biohazard bag to send it down in. Then you go through the actual process of collecting your whole specimen and following your unit's procedure for whichever specimen you're collecting. We need to make sure that it's labeled clearly and that the appropriate paperwork goes with it. It's really important to label your specimen in the presence of the patient so that you have that appropriate chain of custody and you don't accidentally mix it up with somebody else. Then we're going to send it to the lab according to hospital policy. Some specimens might have to go on ice. Some might have to be walked down to the lab. Some can go in the tube system. So it's just important to make sure that you send it the right way. And then after we do anything, we have to make sure that we record it. So making sure that we do a nurse's note about our procedure and also that we're putting the specimen in our eyes and nose. We can collect lots of different types of samples. It's just important that you follow your unit's policy on each type of collection. We also need to remember that we can't collect urine specimens from diapers because the chemicals in the disposable diaper can alter your lab results. So if we have to collect a urine specimen on a patient that's still in a diaper, then we either need to use a urine bag or we might have to catheterize them to be able to get that specimen. So after all of that, we have our first critical thinking discussion. So you're a nurse and you're admitting a 3-year-old boy with a very high temperature who is restless and crying. What safety measure should you institute on admission of this child? So how are you going to keep a restless 3-year-old with a high fever safe?
Make sure it's somebody in the room with them
Mhm.
at all times.
Make sure they're in a crib-like bedding.
Yeah. What do we need to make sure we do with the crib?
Make sure there's
Make sure
nothing
the
around
side
it
rails
and the
are up.
rails are up. Yeah.
Yep. Side rails are up, wheels are locked so it doesn't roll away. What else can we do for a climber with a crib?
They have like a netting thing
Mhm.
they put over it.
Yes, exactly. Making sure we have that plastic netting or whatever your hospital has. Some of them are plastic, some of them are material. But making sure they don't climb over those side rails to get to mom or dad. What else do we need to look for in a pediatric patient that has a very high temperature?
Signs of shock.
Seizures.
Seizures. There we go. Yep. So kids are at risk for febrile seizures. So if they have a really, really high temperature, it puts them at increased risk for seizures. So we need to make sure that we do seizure precautions. So what would that be?
Padding the side rails.
Yep. Padding our side rails. What else?
Well, we monitor vital signs every so often. I don't know how often, but
Yep. We're going to keep a closer eye on their vitals.
Tylenol, ibuprofen to get the fever down.
Yep. We're going to be looking for some medication orders, hopefully, to bring down our fever.
Maybe
Make
like
sure-
a tepid bath.
fluids.
Mhm.
Yes, I say hydration.
Yep, those are all good. what safety measures do we need to make sure? It's something that we should have at the bedside for every patient, but a patient at risk for a seizure is
Suction,
suction. Yeah, there we go. That was it. Yep. So patients with seizures are at increased risk for not being able to handle their secretions. So making sure that we have suction, we have all of our emergency equipment at the bedside. Great job, guys. So now we're going to look at how our children respond to medications. So they're going to absorb, distribute, metabolize, and excrete their medications very differently from adults. Their age is going to be the most important variable in trying to predict how they're going to respond to the medication. So there's lots of things that we need to think about when we are looking at how patients absorb the medication. The first thing is going to be, how did we give it to them? Is it an oral medication? Is it something that we gave in an NG tube, or did we even bypass the stomach altogether and give it straight into their intestines? Was it something that we gave topically or through an IV or eye drops, ear drops, nose drops, anything? We need to pay attention to where we gave it and what influences are going to be involved in metabolizing and excreting that medication. So most medications are going to be metabolized in the liver. They're going to metabolize more slowly than adults because the liver and liver enzymes aren't fully functioning until the child is 2 to 4 years old. So anybody under 2 is going to have a very immature liver and is going to have a hard time metabolizing medications. Our medications that aren't metabolized in the liver will likely be excreted by the kidneys. So our infants that are younger than 1, any child younger than 1, has immature kidneys that prevent proper excretion of medications. So if you're giving an oral medication, you have a child under 1 that's going to have slow stomach emptying, but then a rapid intestinal transit. You've got unpredictable liver function, and now an inability to excrete the medication through the kidneys. So you can see there's a lot of factors that all build up that will lead to toxicity if we're not careful about monitoring our medication levels. So we need to make sure that we're watching for these signs of toxicity. What things would lead you to believe that a child has been exposed to a toxic level of medication? What would you see?
Lethargic.
They could be lethargic.
A rash.
Restless or rash.
Yep. You can have
Loss of
a rash,
function.
nausea,
swelling,
swelling. Yep.
Problems breathing.
Mm-hmm. Could be having an anaphylactic reaction. Yep. Anything else? Yep, these are all things that we need to look out for. Nausea, vomiting, diarrhea, changes in vital signs, changes in their level of consciousness, any rashes, difficulty breathing. We need to make sure that we document all of those things so that we can associate a medication with the reaction and make sure that we have proof to be able to pass on to the next provider. We also need to make sure that every medication that we administer is within those safety doses. So we need to be able to reference a resource to give us the safety dose and then make sure that our order is within that range. Parent teaching is going to be essential to compliance with home medications. So we need to teach them the importance of giving the medication and completing the entire schedule as prescribed. We need to teach them how to measure the dose appropriately. Also give them help with getting their child to successfully take the medication. If you've ever tried to give, especially an oral medication to a young child, it's nearly impossible sometimes. So any help you can provide the parents is going to be greatly appreciated in helping them successfully be able to navigate that at home. And then we also need to encourage parents to write down the schedule and make sure that they're keeping track in written form, especially when you have multiple caregivers that are taking care of a child and parents that are exhausted because their child's sick. It's really easy to either miss a dose or accidentally double dose a kid because you either didn't know the other person did or you thought the other parent did. So having that in writing, especially if you can put it on the prescription bottle, is really helpful in making sure that everybody's on the same page. We talked about different routes for administration. So oral is going to be our preferred route just because we have the most reliable source of, or most expected source of digestion, metabolism. We can also do parenteral medications, nose drops, ear drops, eye drops, all the other forms that aren't oral pretty much. So when we're giving parenteral medications, we usually think about IVs first. So we have different types of IV access that we can use. We have short-term and long-term. Your short-term are going to be your peripheral IV. So just like you would get as an adult, we can either have continuous infusions through a peripheral IV where you're hooked up to IV fluids all the time, or we can have what we call a saline lock or a heparin lock, where we're just using your IV here and there for medications. So no IV fluids, just intermittently for medications. Anytime we're not using that IV, we either want to flush it with saline or heparin, depending on your order, to make sure that we keep that IV nice and patent. So our kids have very, very small blood vessels, and it's really easy for blood clots to form at the end of your insertion site and block the end of your catheter. So if we're routinely flushing medication through our IVs or using that saline, then we make sure that we don't get that blood clot at the end of our line. Then we have long-term IVs. So you can have a PICC line or a central line or a port. Those are all going to be for long-term antibiotic use or multiple medications. Your hematology and oncology kids are likely going to have implanted ports just so that we're not having to constantly poke them for labs. So those are all things that we can use for parenteral therapy. We need to make sure that we're assessing our IVs for patency, and then we're also looking at our dressings routinely to make sure that they're still occlusive so that our line is secured and that we're not potentially introducing sources of infection. We'll talk about IV safety a lot more. When we're giving IM injections, we need to make sure that we're using an appropriate volume. If we introduce too large of a volume, we can cause muscle and tissue damage. So we need to make sure that we're paying attention and choosing the right site based on the amount of medication that we have. So our infants can't tolerate more than 0.5 milliliter. Our infants can, or our toddlers can take up to 1 milliliter. And then our school age and adolescent children will depend on which muscle site you use. So only 1 mil in the deltoid, you can go up to 2 in the vastus lateralis. So just making sure that we're matching the right site with our medication volume. When we give IV medications, those are going to go directly into the bloodstream. So they're going to be absorbed a lot faster. You're going to see the effects a lot sooner. than you would through an oral or topical route. We have to make sure that we're monitoring the insertion site for patency and watching for infiltration or inflammation. Medications given through an IV can cause phlebitis or irritation to that blood vessel. So you can see the picture, you can kind of see the picture up top. You see those really red kind of puffy fingers with that white blanched palm. So that's an earlier sign of an infiltration. The bottom picture is a late sign. So you've got some discoloration. You've obviously got some vein irritation there. So that IV likely infiltrated and was sitting that way for a little bit. So that's why it's really important that we're assessing our IVs and we're using our parents too. Especially if parents are rooming in, we need to teach them all of the signs of an IV infiltration so that when we're coming through and doing our hourly checks, we're looking for it, but they're also looking for it those 59 minutes that we're not in the room. So they will be your best advocates for your IVs going bad. So in addition to looking at the site, we also need to make sure that we're not going to run out of IV fluids in our bags. In our pediatric patients, we use a burette, which is like a little cylinder that hangs underneath your IV bag that allows you to have more accuracy in your measurements. So it's got a lot smaller units on it so that you can be really accurate with your measurements and make sure that you're only administering what you intend to. So making sure that we have volume in both our bag and our burette so that we're not getting air into our IV line. We talked about the rate and flow. So that's where your bag and your burette come in. Making sure that our IVs are getting the right, we're checking our pump volumes, making sure that what we think is going in is actually going in. Any moisture at or around your needle insertion site is an indication that your IV might be going bad. And you've got IV fluids that are just going into the tissue around your IV and not actually into the vessel. So that's something else that you want to look out for. And we need to make sure that we're keeping accurate eyes and nose for any child that's on IV fluids. So that will be included in all of your documentation. When we're taking care of a child with IVs, we need to make sure that we are considering the developmental level of the child. How active are they? When we're placing our IVs, we need to make sure that we are placing them in an appropriate location so that we're still allowing them as much range of motion as we can. We're not, if the child's right-handed, we're not putting it in their right hand. We want to try and avoid their dominant hand so that they can still do as many activities for themselves as they can. So choosing a good site that's going to make for happy parents, happy kids, makes for a happy nurse. Making sure that we do all of our related nursing actions. So making sure that we're educating our parents, making sure that we are protecting that IV site. We might have to wrap it so that the child can't see it where they want to pick at it and poke at it and pull. We need to make sure that we give them some extra slack in their IV tubing. So if they accidentally pull the tubing or trip on it, that it's not just going to instantly pull your IV out. Making sure that we're doing those mobility considerations. So making sure they can still get up and move around as they're able to, teaching parents how to move around with an IV pole. Probably encouraging them to have a nurse the first couple times they get up and down. And then making sure we do those safety needs. So encouraging a nurse when they're getting out of bed, making sure that we're not pushing buttons on our IV pole, making sure that, you know, we're not off the unit for an extended period of time where we could run out of medication, all of those things. Anytime that we give a medication, we need to make sure that we're doing the 6 rights of medication administration. So we have the right patient, the right drug, the right dose, the right time, the right route, and the right documentation. So what would happen if we would miss any one of those 6?
Patient at risk. Or
Yeah, you put your patient at risk. Either you didn't give them a medication or you gave them the wrong medication. Either way, you're at risk. What else?
You can like give them
Put
drug
another
overdose.
patient, you could put another patient at risk.
We can have an overdose. We have other patients at risk. What if we don't document a medication?
And you didn't give it.
Over medicate.
You
That's
can
what everybody would
over-medicate,
think.
over-medicate, under-medicate. You could have a reaction that nobody knows the cause of because you didn't document what medication you gave. All of those things could come into play if we don't follow those 6 rights. So that's why they're so important.
Or like a drug reaction.
You can have medication reaction. So if they received one medication and then you gave something else and the two compete with each other, we can have drug reactions. So when we're calculating our pediatric drug doses, we have a couple different methods that we can use. We can use body surface area, which is going to be one of the most accurate forms of calculation. The one you will use most often is going to be milligrams per kilogram. And then we can use dimensional analysis to figure out what we have versus what we want to give and figure out what it is that we actually need to administer to the patient. We talked about things to consider with our IV. So any extra devices that we might need to help secure that IV. Do they need an arm board to keep their arm straight or to keep them from pulling? Making sure that we include the family as much as possible. They're going to be your best advocates. They're also going to be a lot of help for the insertion process. So if you can have parents there at the bedside to help you, it will really help the child tolerate it better. Some parents just can't handle it, and that's understandable. But involving them as much as you can will really be beneficial to you and the child. So like we talked about with the 6 rights, we need to make sure that we're preventing those potential drug interactions. So we need to be cautious of drug and environment interactions. So things like phototoxicity. So medication can make you extra sensitive to light and put you at increased risks of burns if you're out in the sun a lot. The same thing is true of the medication itself. So some medications are very light sensitive and have to be covered in like a dark plastic bag if they're going to be exposed to light so that they don't break down. We also have drug to drug interactions. So some medications just don't play nice with others. So it's important that we watch for those. We get an accurate medication history for anybody coming in from home so that we avoid those drug to drug interactions. Then we also have drug to food interactions. So certain foods don't mix well because they either increase the absorption of a medication or they prevent the body from absorbing and metabolizing the medication. So watching out for those types of things. Especially our infant population, we sometimes have to help them with their nutrition. So sometimes they need outside sources to be able to adequately nourish and grow. So when babies can't take food by mouth, but they still have an intact GI tract, we do what we call gavage feeding. So we put a tube in their nose or their mouth that goes all the way down to their belly, and we can give them that extra nutrition that they can't take by mouth. That way they still get the natural digestive process, they're still getting their gut perfused, still doing all of those things, but it doesn't take effort on their part. So we need to make sure when we're doing gavage feedings that we're measuring our tube. So typically from their nose to their ear and down to their belly. making sure that it's in the right location before we start our feed. Making sure that we don't have a bunch of leftover feed in their belly from the last time. That might be an indication that they're not properly digesting, and we might have to hold a feed or give only a partial feed. And then we also need to be careful about how high we're holding our syringe. So you can change the speed of how fast your feeding flows in by the height of your syringe above the baby. So this is something that we can teach parents to do, and they can do at the bedside, especially if they're going to be in the NICU for a long time. It's really important that when we're doing gavage feeds, we still allow the baby opportunities to suck on a pacifier so that they can develop those skills. They also need to be held so that they associate that full belly and that satisfaction with the love and nurturing that they would get from being held. All of those things go into play with our gavage feeds. When we're looking at a long-term solution for a baby that can't eat by mouth, we use a gastrostomy. So there's a couple different types that we can use, but this is a tube that's going to be surgically placed through the abdominal wall into the stomach. So the top one, you can see a Mickey button. Those are the most common. They're going to be used in infants, children who can't have food by mouth because they either have an anomaly or a stricture. They might have a severe debilitation that means they can't neurologically function anymore. They might be in a coma. All of those things would be reasons to have a gastrostomy. Things that we need to look out for, we need to watch for brown or green drainage around that insertion site that might indicate the tube has slipped out and can cause an obstruction. So that's something that needs to be reported immediately. You can see that we leave dressings on them, and that's so that we can protect the skin around the site from any stomach contents, anything that we're giving. We want to watch for skin breakdown, making sure that we're not having stomach acid leaking out around that G-tube site and causing skin breakdown. When we give enemas, it's going to be very similar to what we do with adults. Obviously, we're not going to be able to give as much as we do with an adult because our kids have a lot smaller bodies. We also aren't going to stick the tube in as far because we don't need to go all the way to their stomach. They're just going to have a little insertion. And then the important thing to remember is that we only use isotonic solutions in our pediatric population. So tap water is going to be contraindicated because it's a hypotonic solution, and it can cause a fluid shift and can end up with a child with fluid overload. So if you use a hypotonic solution, the body absorbs it through the intestinal wall and can cause fluid overload. Our respirations, we are watching for signs of respiratory distress. So things that we want to watch for are restlessness, a rising pulse rate, fatigue, apathy, any pain or difficulty breathing, sternal retraction, so that's sucking in at their sternum. You can also see it between their ribs. You can see nasal flaring where their nostrils just go. Any change in their skin coloring, so pallor or cyanosis. And then if they do have a tracheostomy, you want to watch for inflammation or drainage around that insertion site. So we can have a lot of these respiratory difficulties will lead us to want to suction a patient. So reasons for suctioning are going to be noisy breathing. If you can visibly see mucus, you listen to them and you get that really wet cough or really weird sounding lung sounds. That if we don't suction a patient, it can put us at risk for accidental extubation. So especially our toddlers, if they can't breathe, they're going to immediately just reach up and rip out that tube. They're not going to understand the reasoning behind it. It's just going to be in the way. Some complications that might lead you to needing an advanced airway are going to be a tracheoesophageal fistula, If you have any stenosis or narrowing of your airways, tracheal ischemia, where you don't have adequate blood flow, infections can cause a lot of respiratory difficulties. Then atelectasis is where your alveoli in the bottom of your lungs don't stay open, so they stay collapsed. So when you breathe, they just barely move. You don't get adequate gas exchange. And then with those advanced airways, you can have cannula occlusions that you need to watch out for. Anytime you have an airway obstruction, you need to know the appropriate way to manage that. And for our infants, that's going to be their chest thrust followed by their back blows. And then for our older children, we can do the same thing that we do with adults. So do just those abdominal thrusts. With our kids, you're going to have a lot easier time getting around them. So you won't necessarily have to use a chair or another object to be able to reach around them and give that abdominal thrust. Surgery is a very difficult and very stressful time on our kids. So they need both physical preparation and psychological preparation. So if you've ever been inside a pediatric hospital, you know, they're bright, they're colorful, there's lots of fun things to look at. Then you take them into the operating room and it's a sterile environment. There's no colors. Everybody's got their hair covered, they've got a mask on, so they just look like this floating set of eyes coming at you. Then we've got floating eyes coming at you. We're taking you from your parents and we're giving you medication to put you asleep and likely removing something from your body. So you can see how that would be a very traumatizing experience for a young child. So we need to make sure that we give them adequate time to cope with the whole process. Make sure we give them lots of time for explanations, that we explain that we're not going to go in and like take off their whole leg. They know exactly what to expect. Clarify any misunderstandings that they have. Give them an opportunity to see the area if you can. Give them a chance to play with any equipment that they might see. Those are all things that will help them mentally prepare for the whole experience. Infants can't be maintained NPO more than 4 to 6 hours because they can't regulate their blood sugar much longer than that. So making sure that we're not keeping them NPO for an extended period of time, that we're also giving them that pacifier so that we're meeting those developmental needs for sucking. As soon as surgery is over, the main goal is getting the child back to their pre-surgery state as quick as possible. So they're going to want to be up, they're going to want to play. We need to make sure that we have appropriate pain control in place so that they can do those activities that they want to do. Making sure that we are getting them back to their normal state of being. Okay, so this is, this question is a little out there, but really important for us to think through. So an infant who still wears a diaper was admitted to the pediatric unit with diarrhea that lasted for several days. The physician has ordered the application of hydrocortisone cream to the infant's right buttocks. Should the nurse be concerned about this order? What do you guys think?
Yes.
Yes.
Yes,
Absolutely.
because the cortisone and the steroid
Mm-hmm.
causes problems with fighting off infections and stuff like that.
Mm-hmm. What about the hydrocortisone and the diaper? Does anybody know what can happen when the two are combined?
It'll explode. It'll like
Not explode, but
but the reaction like not explode, but it'll go the what is it, the lining or whatever, it just gets everywhere.
yeah, so the hydrocortisone can have adverse systemic responses. So the plastic in the diaper can cause an increase in the absorption of the medication. So when the two come together, then there's an increased absorption of your hydrocortisone. So very high risk of toxicity there. Also, is hydrocortisone going to be good for a kid that's had diarrhea for multiple days to protect their bottom?
No.
No. What are we looking for when we're trying to find a diaper cream?
Lecithin or like Vaseline.
Mm-hmm.
Oh.
Yeah. What's the purpose behind it?
It beats
Barrier.
off the barrier, right? Beats
Yep.
off water.
Exactly. Yep. So we need that barrier. We need to protect the skin from everything going on in the diaper. So we create that barrier using either Aquaphor, Desitin, whatever your hospital provides, a zinc oxide, an emollient, something to make that nice thick barrier to protect your skin. So hydrocortisone isn't going to do that at all. So that is definitely a time that you're going to question your physician's order. Definitely not what we're looking for here. So that is the end of our PowerPoint. Does anybody have questions over any of the material that we covered there? Okay. I am working on getting our Kahoot up and ready. So we will do that next. Okay. So I will let you guys get logged in. We got lots of Halloween characters this time. Is that everybody?
Professor, I'm not able to log into the Kahoots.
Is it not letting you?
It's not that I had water damage on my phone, so my phone is like,
Oh. Okay. No worries. You can just follow along on the screen and answer them for yourself.
okay,
Yep, no worries. We just do this for fun and for practice.
okay.
Okay, guys, we'll go ahead and get started. So after we give nose drops, we need to keep the infant flat or in a head down position for at least 30 seconds to 1 minute. So typically, if we're going to give nose drops, we're going to have them laying in their crib. We want them to stay flat for that full 30 seconds to a minute so that we make sure all the medication makes it all the way back through their sinuses. And then it's not just sitting in their nose, then we sit them up and it comes right back up. So making sure we give it ample time to make it all the way back. When planning care for a toddler, what behaviors do we need to consider to promote security? So if you remember, our toddlers love routine, they love schedule, they love to be able to know what's coming next. And that's going to help them feel secure in their environment. So ritualism or sticking to that schedule that they're used to is going to help promote that security. Latency is one of Freud's theories, and that's all about relationship development. And we see that more in our school age population. We see negativism in our toddlers, but that's them trying to assert their independence by constantly telling you no to everything, which we know they're really good at. And then orality is going to be seen in the infant population, and that's where they're exploring everything by putting it in their mouth. So ritualism promotes security among our toddlers. So Maslow's hierarchy of needs, that was that triangle that they have to meet the very bottom level, and then they move all the way up to meet fulfillment. So measuring vital signs and O2 stats is going to be at the very bottom level of those physiological needs being met. So their body is able to function. A child explains to the nurse that he got sick because he went swimming in the rain. According to Piaget, that is concrete operational thinking. So a very logical cause and effect relationship for determining why we got sick. Gentamicin eardrops are prescribed for a 4-year-old. How would the nurse position the auricle? So the auricle is the outside of the ear. So we need to remember in our pediatric population that we have to pull the ear up and then back to be able to straighten out their ear canal to get the medication all the way in. The best location for a nurse to assess the pulse rate on a 12-month-old infant is going to be that apical, actually listening for that full minute to the heart to make sure that we're getting an accurate reading. So you can take a brachial pulse, but listening is still going to be more accurate. You're not going to have those perfusion issues that could cause altered readings. Definitely don't want to do radial because their peripheral perfusion isn't necessarily the best. So you might not be able to feel a good consistent pulse. Femoral is going to be the same thing. You're not going to have those extra things. Also, a 12-month-old probably isn't going to sit still long enough for you to be able to actually assess a femoral pulse. They're going to be kicking at you the whole time. So that apical pulse is going to be your best bet. Four-year-old child asks tearfully if the IM injection will hurt. What is the nurse's most effective response? The answer is yes, it will sting a little. So we need to be truthful with the patient and be honest. Yes, it's going to hurt a little bit, but we don't want to provide extra fear. Like, yes, we're going to hurt you. We don't want to say that we're going to hold them down. That's just going to make the anticipation even worse. We do allow restraints and comfort holds from parents. So parents being involved in holding their child really does help with the tolerance and keeping that trusting relationship. We don't want to give them the syringe with the needle on it because they could spill the medication, they can poke themselves. So we definitely don't want to provide another safety risk. And then lying to them and saying, no, it's over before you know it is going to damage that trust relationship that they have with you because it is going to hurt. So yes, it will sting a little bit is going to be your best answer. What antibiotic is known to cause discoloration of the teeth in young children? and that is tetracycline. So you can match your T's and teeth. We want to make sure that when we give tetracyclines that we are either administering them with a straw and making sure that we're washing the child's mouth out afterwards so that we don't get that discoloration of their teeth. A parent tells the nurse, "I'm not sure how to give this medicine to my infant." How would the nurse teach the parent? So the safest way to give medication to an infant is going to be through an oral syringe that you put in the side of their mouth. So this way it allows the medication to drip into their cheek and they can swallow it as they're able. If we put medication in a nipple, there's a good chance that it might clog the nipple, might get stuck. You've got some transfer of medication that doesn't get pushed through, so your dosing might not be accurate. We definitely don't want to mix it in with their feeding because it might keep them from taking their feeding if it alters the taste. You can also have those medication food reactions if you're mixing their medication in with milk. We don't want to use a cup because they don't have the swallowing reflexes to be able to drink from a cup. And then administering it on the back of the tongue with a dropper is going to be the same risk. You could have an aspiration. When should a child be able to feed themselves or begin to be able to feed themselves with a spoon and a fork? And that's going to be 2.5 to 3 years. So at that 2-year mark, they're still going to be focused on finger foods and not quite have the dexterity to be able to use silverware. So that extra 6 months really gets them that dexterity that they need to be able to hold their silverware effectively. Should parents be concerned about how much fat they include in their young child's diet? So we need to remember that children under 2 need that fat in their diet to promote growth and that brain development. So it's a really important part of their nutrition for those first 2 years to have those full fat foods. What type of play are toddlers known to do? And that is parallel play. So understanding the different types of play is going to be really important for you. So they start in parallel play where they're playing next to each other, but still doing completely independent things. Then from that, they graduate into associative play, where they'll both do the same thing, but they're gonna do it independently of each other. Then graduate to cooperative play, which is the last stage where they can both work together on the same thing. So understanding that progression is going to be really important. Which restraint is most appropriate for the insertion of an IV in the scalp of an infant? So for this, we're going to use a mummy restraint. So we're going to want to have a pretty good hold on them if we're putting an IV in their scalp. So the mummy restraint keeps their extremities down. It also keeps their head from moving too terribly far, so that you have the best chance of securing that IV in their scalp. That will be an absolute last resort for our infants. It's very traumatizing for the parents to see an IV in their child's head. Also, they're really easy to pull out. So, there's not a lot of fat, not a lot of tissue up here to be able to hold your IV in place. And it's really easy for that tubing to just get caught either in the infant's arms or in parents' arms. So it's really easy for those to come out. And when they do come out, they tend to bleed a lot, just because it's your head. Anytime you get a cut on your head or your face, it tends to bleed a lot. So that whole experience can be traumatic for the child and the parent. So we use that as an absolute last resort. So we do hourly assessments on continuous IV infusions. So this is because our IVs can go bad so quickly. We need to make sure that we have eyes on them at least every hour. And then having our parents help us for those times that we're not able to be at the bedside. So our most accurate method of determining the correct dose for children that's listed there is going to be your body surface area. The other thing that we use most often is going to be that milligram per kilogram dosage calculation. According to Kohlberg's conventional morality, school-age children believe following the rules is the right thing to do. So in that school age, you're having that logical thought process. So we follow the rules because it's the right thing to do, because that's what makes mom and dad happy. So that logical understanding of morality, where you've got a cause and effect there, that's where our school age kids are going to be. Our toddlers are going to be more so in it for the rewards of, I get a sticker if I put my clothes away, things like that. Their school age kids aren't going to be able to rationalize anything yet because they don't understand abstract thought. And then always doing the right thing, even if it breaks the rules, isn't in line with any form of morality. Good job, guys. So Freud's level of or stage of latency is related to our children forming relationships. Adolescents are all about body image. According to Erickson, that's going to be your identity versus role diffusion. So all about who they are, what's important to them. Their body image is going to be part of establishing their identity. The final stage of Piaget's developmental theory is going to be that formal operations, where your adolescents are going to increase their moral reasoning. That's as far as they can go. So if you remember, his adolescent stage was the very last stage. A mother is concerned her child has developed a fever after an immunization. What education should the nurse provide? And we need to remember that fevers after immunizations are part of the normal immune response. So we want to see that correlation. So our immunizations are going to be introducing that virus into the body, and we're going to have that normal immune response to it in order to develop that immunity that we have in result to getting that immunization. So part of that is going to be the fever so that we get the prostaglandins and we get that immunity built up. So if we ask a child, would you please take your medicine now? The response 100% of the time is going to be no. They're in that age where they do not want to take medicine. If you give them a yes or no question, the answer will always be no. So that's never going to get you anywhere. If we compare them to another child, we could cause them to feel guilty about not being able to do something or not wanting to do something. So we definitely don't want to be comparing them to other children. You must take your medicine now if you want to get better. That is a negative form of speaking. So can cause your child to feel bad about themselves, can really diminish their self-esteem. Also, still doesn't get you where you want to go. If you come at them angry, they're going to be equally angry at you. So the best answer here is it's time for your medicine. Would you like water or juice after it? So you're giving them an opportunity to make a choice, but in order to make a choice, they need to do what you would like them to do. So that's going to be your best approach for administering meds to a younger child. Good job, guys. 2-month-olds with propped formula bottle. So that's going to increase your risk of choking. So the child's not able to get away from the bottle if they have too much liquid in their mouth. They can't turn, a 2-month-old can't roll yet, so they can't roll out of the way to get rid of it. So really increased risk for choking by propping that bottle. Action that we have to stop immediately and provide that parent or peer education if we see another nurse doing it. Six hours into a 24-hour urine specimen, the child is incontinent. What instructions should be provided to the parent? So during a 24-hour urine, it's really important that we have every single sample so that we have an accurate volume and then we have accurate components of what's in the urine over that 24-hour period. So if we lose any specimen, we have to completely restart the test. So as unfortunate as it is, 6 hours in, we have to start over so that we make sure that we're getting accurate interpretations of our labs. When we're looking for spinal fluid, then we're going to do a lumbar puncture. So that's when we're going in between the vertebrae to access the spinal cord to be able to get that spinal fluid. Thoracentesis or a needle aspiration are going to be used more often when we are trying to treat a pneumothorax. So if there's air in the chest cavity and it's causing the lung to collapse, we can do a thoracentesis or a needle aspiration to be able to remove that so that the lung can fully expand. And then a bone marrow aspiration is where we're actually drilling into the bone, typically in the hip, and getting into that bone marrow to look at the components of the blood. So you're going to see that a lot in your hematology and oncology population. Nursing interventions for a lumbar puncture with your infants, you're going to have them laying on their side and you're going to round them into that nice C shape so that their vertebrae split and the physician can get to the spinal cord in between the vertebrae. For your older kids that can actually sit up on their own, you're just going to have them sit up and have them bend forward as far as they can go. And you're going to help hold them in that bent over position. The most effective position for a nurse to place a toddler to administer medication is going to be semi-Fowlers in a crib. So if they're standing, they're going to run from you. If they're sitting in a high chair, they have the opportunity to like throw their head back and get away from you that way. If you have them in a crib, at least that way you can have them seated upright a little bit or seated upright a little bit so that you don't have that risk of aspiration, but you also have a solid surface behind their head so they can't fight you as much. If you have them semi-sitting on your lap, you're going to be wrangling a squirmy toddler trying to get them to take the medication. So probably not going to go very well. Also, if they're semi-sitting, you could have them choking as they're trying to get away from you. And very likely, if they're sitting in your lap, they're going to spit their medicine on you. Much easier to change linens than it is to change your clothes. So definitely keep them in the crib where they have that sense of security. And you have the best opportunity to keep the medication in. The most significant reason for obtaining an accurate weight on a hospitalized child is going to be for those medication doses. Yes, we do want to be able to plot their growth on the growth chart, but most important is going to be for medication administration. So let's see who our winner is. Congratulations, Miss Kenya. You are our winner tonight.